Okay, this is very exciting today. I welcome to Good Luck Luke. I'm very honored to have both Dr. Jessie Hade here and Kelli, who is Dr. Hade's patient, being here joining our podcast. So thank you. I'm very honored to have both of you to be here.
Thank you for having us.
Kelli, this is a very different format in some ways because some of our clients or patients are now they're my friends. They would just talk and we're like, hey, Dr. Luke, do you remember? And they'll be like, oh, yes, I remember. But then Kelli, I know your journey has been majority with Dr. Hade. Mm-hmm. So I want to first start with how did you find Dr. Hade and how did you find Generation Next?
I was trying naturally for a while, and I was going to acupuncture regularly. Okay. And my acupuncturist recommended a couple of clinics, and Generation Next was one of them.
I see.
My acupuncturist, and I've heard this from a lot of friends trying to conceive, just was like a therapist also through everything besides just treating me once a week, but really helped talk me through some things. But that's how I found Generation Next.
How long was the process with the with the acupuncturist before you seek?
We tried for about 5 months.
5 months, okay.
Because I was 38 when I started trying. I turned 39, and we decided we should just go ahead and go to someone and see what was going on.
Oh, wow. So when you arrived, what was the treatment that Dr. Hade or?
Well, I started with you.
Oh, yeah. Sorry, Kelli.
Yeah, no, it's okay. It's been a long time since I saw you. But I saw you first and learned that I had diminished ovarian reserve.
Yes.
Which was really terrifying. We did one round. I got a euploid in the first round.
Yes,
which was
I remember that.
Very
amazing,
triumphant, and great. But we realized that we needed more. Yes,
and then.
So
there was really one check. AMH was very low. We had very low AMH, and true follicle count was also low. I think it was only 2 or 3 follicles. Thank you.
2 and like 1 that wasn't mature
really small,
yet.
Right? Yeah. And then it was very hard to get to this one normal. Yeah. But then I still remember that call. See, I have those memories once it comes back. But then afterwards is how do we get the second one?
Right.
Is where we got into trouble.
Right. The second retrieval, we didn't get any.
No, we
didn't get any. But I think that what had happened at that point was that Dr. Hade did the retrieval.
Yes.
And one of the eggs at that point was just not ready yet. It wasn't big enough. So he suggested luteal phase retrieval.
Yep.
And, when we were dealing with such a small amount of eggs, luteal phase made a lot of sense. I mean, financially, it wasn't such a whole entire other retrieval,
Right.
And every single egg counted. So we moved to him and we did the luteal phase, and we got one more from that cycle.
And luteal phase, just to explain to audience, is basically stimulate at the beginning when you have a period, that's called follicular phase. Right. And then you stimulate again right after the retrieval. It may take about 1 week, sometimes less, to get to the second egg, or longer actually, to get to the second retrieval.
Right, and it's not guaranteed that you won't, after you ovulate the first time, that the rest of the follicles will stay and continue to grow.
Yes. And Dr. Hade, how did you counsel with luteal phase? I usually say 70% egg, 30% cyst. Like, how did you usually?
That's pretty accurate. When you look at the data, so for women, and Kelli was a little younger at the time, but because you can't really look at just age brackets because it also reserve matters. So when you look at just overall for women who are 40 years of age, the number of cycles that they need to achieve a live birth is quite high, much higher than most people realize. So at 38, 39, with the low reserve, your body's acting more like in a more mature, more advanced state of age. So just by when you have like 2 or 3, to go from 2 follicles or 2 eggs to 3 eggs, you're actually increasing at 38, 39, you're increasing your chance of pregnancy by between 20 and 30% per extra egg you get. And you're right, because with luteal phase, one of the advantages is that you're having lower costs because it's less medication. Your body's naturally stopping you from ovulating from the high progesterone, so you don't need to take like, any antagonists. Everything adds up, and everything's a cost. We're also at Generation Next Year a little bit less expensive on the luteal phase. We try and give people a break on the cycle expense, and also you're usually doing less days of stimulation. If you look in that population in the follicular phase, it's about a 16.5% cancellation rate. With LPS, it's a little bit higher. It's about 22.5%. So you have slightly higher cancellation rate just because these follicles, some of them don't respond. But the ones that do, usually will get equal or greater numbers of eggs retrieved, and the blastocyst formation rate and the euploid rate is actually identical.
Right. It's not much higher.
So you're doing these cycles for less money. So it's, and especially time is of the essence as you're getting older, and like you mentioned, which is super important that people have to realize. Otherwise, if you had to do 3 cycles to get like 4 or 5 eggs, that could take you 3 to 4 months to do versus we're getting it in 6 weeks if you're doing it. And I've had patients who, Kelly's lucky because she could do it in 2 cycles in one time, but some people, or even 30% of patients, will have 3 cohorts of follicles. And I've been able to do continuous stimulation for up to 6 weeks in women in their mid-40s. So I could do 3 months worth of treatments in 6 weeks worth of time.
That sounds very unpleasant for the patient, but very rewarding in the end. Obviously, the outcome is the most important thing.
For a short frame of time, but then they don't also have to go. Then they go take a break. They don't want vacation.
It would be completely worth it for someone who so desperately is trying to. Yes.
So Kelly, talk to me a little bit. Was I the first doctor described to you diminished ovarian reserve?
Yes, I didn't
or
know what
you
that
didn't
was.
know? Okay, and you knew you're not going to be like, because on internet there are lots of information, and the women like, I got 20 eggs, I got 10 eggs. You kind of know you're not going to get 10, 20 eggs from the ovarian reserve.
Right. I mean, I didn't really know that much about how my reproductive cycle worked, which is kind of shocking to say. And I mean, I feel like a lot of my friends didn't either. I was explaining things to them once, we know about, the basics.
That's very
the birds and the bees,
point.
But all of the follicles and how things change as you get older, we just didn't really know.
And we didn't use too high of a medication with the first cycle.
Okay.
That is what
I don't exactly remember. I don't remember it changing a lot, but maybe you increased it a little bit.
Yeah, I wouldn't consider with the second, or the whole reason is I was just talking about to my colleagues about fertility paradox, is that certain patients when the follicle count is so low, more medication may not produce the same effect. So that's something that so now, how did you and Dr. Hade get to know each other, and how PRP came into play? And
so we did the second round, or he did the second retrieval, and then we did the luteal phase. I did a total of 6.
Right.
Generation Next packaged it in groups of 3 cycles, which I found to be very helpful. I mean, very cost effective. So, and I knew from the beginning that I was going to need more retrievals than a lot of women. So we, let's see. So the third cycle, I believe when we started, maybe you told me about PRP. I didn't know what that was. I mean, it was very new at the time, right?
So this was like 2021, 22?
Yes, 2021.
Just when we started doing it. That's when we first started.
Right, because it was the question of, okay, what can I do to get more follicles?
Right.
And it was like, I remember, talking about the option of donor eggs, and then talking about, well, PRP is the only thing.
But we had 2 now, or not yet.
We only had one at that time.
The one that we got, the first.
Yeah. So I think that we did the first PRP injection before my third retrieval, because it was a total of 3 PRP injections. So the third cycle, though, I only had 1 embryo saved at that point. The second cycle, we got 3 eggs, but none of them made it to blastocyst. So by the third cycle, I just wanted to save something and freeze something so I'd have something. So we saved eggs, our embryos on day 3 without testing or anything like that, just so there would be something banked. We knew we were going to do more. So then we did another round of PRP before the 4th cycle. I didn't see a change in follicles at all. Where am I at? The 4th now. The 4th cycle. Yes. But the 5th cycle, and mind you, I got 2 eggs. Sometimes I think one I even just got 1 egg. But by the 5th cycle, I had 6 follicles growing.
Oh wow!
Which amazing. Was incredible. Like some kind of miracle. I know it's medicine, but I just remember being so excited. And then we ended up getting 4 eggs that fertilized.
Oh, wow. Okay. That part is now departed from me. So I didn't know about this amazing results. And then what was the euploid?
Yeah, and then 3 made it to blastocyst.
Wow.
It's amazing.
And then we got a euploid. So we had our 2 euploid, which is... kind of what I had established in my mind that I needed to have some success. We only want 1 child.
Right.
But we had another cycle. The 6th cycle was already paid for.
Right.
So, except for the medication. But we decided, let's just go ahead and go with this. I'm not getting any younger before. I didn't want to have to go back. And backtrack and do more retrievals. Right. So we did the 6th cycle. I was expecting 5 or 6 eggs, or maybe more, because we had done another PRP. So I think at the beginning I had maybe 7 follicles growing, which was more follicles. I was very excited. And then one of the follicles started to grow and the rest stopped. One of them just took from all of the other follicles. And I was really upset and very disheartened about that. I remember a friend of mine who had gone through IVF before me and sort of talked me through a lot of it, because she just knew what was coming after every step. And she was like, maybe this follicle just knows what it's doing.
Okay.
Just trust this little follicle. So we did it. We got 1 follicle. We got 1 egg. It made it to blastocyst, and it was a euploid, and that's the baby.
Oh, okay. Yes, I didn't tell Audie. You are now how many weeks, Kelli?
31 and a half.
31 and a half. Okay.
And it was that last that I had no hope for. I was like, this is just totally a wash.
Yes, that's amazing. So why PRP was suggested? Is it because we want more follicles, Dr. Hade? And I just want to hear the logic and thinking. And what kind of patients would benefit? Because Kelli is also saying, hey, my limited amount, I cannot keep on forever doing 8 retrievals. Because now I'm coming up with patients who come to me and say, I'm doing 3 cycles with you. Maybe we should talk about PRP now versus PRP after the 3 and that doesn't work and then So when do you interject? Because right now it is such experimental still data. And yes, I'm also a little bit reluctant to tell patient, go PRP, and did meet Kelli and say PRP before her first cycle. Right. When does that interject? And do we think PRP did have an effect for us to get this euploids, which we don't know, I guess.
These are all great questions, and there is no simple answer, and that's the problem, because when you look at what PRP is, you're just taking the body's natural healing properties and you're trying to concentrate them and then directly inject it into the target organ or tissue that you're looking to improve. And like you mentioned, it is experimental. So I agree with you. You don't offer experimental therapy as primary modality to help people achieve pregnancy. And I think everything in Kelli's story exemplifies how things should work. You're going through, and you'll never know because she's going through treatments. She has low reserve. She did several cycles and only ended up with either 1 egg and 1 embryo euploid. So obviously that's a great sign. Tells me more than likely there may be more down the pike, but you don't know. And so when you're trying to say all PRP is trying to do is just improve the environment within the tissue so that when there are follicles, and what I love to hear from Kelli's story is what most groups find, like 60 to 70% of patients who are exposed to PRP for what's called or considered ovarian rejuvenation will start to increase the number of follicles and potentially number of eggs and embryos formed. So as we mentioned before, it's a numbers game. That's the problem with everything, because we're not changing, Dr. Luke and myself, are not changing what you're giving me. So if you're making bad things that can't create a live birth, all I may end up doing is making more bad things that don't create a live birth. And that's the concept of, does PRP with all the different growth factors and all the different elements, cytokines, instructional proteins, are you telling these follicles to not only improve what they're doing and can they actually make better quality eggs? And that's why we're doing a true clinical trial to look at this, because you have to say, I can't just give you PRP and say, did it make a response? Because in reality, as we mentioned and we talked about before, that you and I may do things subconsciously when we're doing a therapy and not realize that we're changing the outcome. It's like that famous physics experiment with the double slit. When you're not looking, it does one thing, and when you're looking, it does something else. And maybe by looking, we're actually changing the outcome. And that's why if you and I don't know what we're doing or what we're getting, what you're receiving and what I'm giving you, then that takes that bias out, and then you could really see what the true value of any therapy is. And it's hard to do, as you know, in medicine, because what we do is a very emotional treatment. It's next to, I think, when someone's diagnosed with cancer, probably the most emotional aspect of medicine, where people have their own bias in what they want to do. And it's not our job to sway them from the bias. We just have to give them the information so that they can make the correct decisions for themselves. And I think after having a long discussion with Kelli, and I know that when we were doing this, we didn't even have any preliminary data. So
there was 2000. Yeah, that's not much data.
Not much. And we have a lot more now that substantiates some of this. But again, you have to look at classic like physics double slit experiment, that because if I'm looking at it, am I changing the outcome versus when I'm not looking at it? So that's an interesting thing that we don't know.
It is funny. Today I was talking to a life coach, basically, who is a fertility coach, talking about the stress that some cancer patients undergo is similar to the stress they did a study where the level of stress and the degree of distress is similar to a fertility patient and a cancer patient. Like a cancer diagnosis and fertility diagnosis is very similar.
It makes sense.
The stress that one go through. So Kelli, after we got the embryo and the transfer was seamless, did you guys do all the evaluation? Because this is where me and my patients, I know you and Dr. Hade at that point, we're talking a lot like how to evaluate the uterus, what to do, because now Kelli knows there are lots of tests out there nowadays. There's a receptivity test, there's resectiva, there's endometrial biopsy test. What did you both decide before the transfer?
Yeah, we did the receptivity test. What is it called?
It's the ERA.
Yes, we did the ERA.
Okay. And then you also did the hysteroscopy, right, to take a look at the uterus.
I actually did miscarry one of the euploid.
Right.
We ended up with 3 euploid.
Because that's what I was going to have you mention that. Dr. Hade mentioned that to me.
The first transfer did implant, but at 6 weeks we saw that it was a blighted ovum.
Do you remember which embryo that was from? Was that from
That was after PRP. It was the second that we had gotten.
The second.
Right. So the one that we have still waiting.
The one that we have still waiting is the first from the first retrieval.
Okay, so I know.
And I don't remember why that is. I just we weren't choosing based on anything other than quality.
Okay. Yeah, it may have been a day 7 embryo. That's why.
Yeah, maybe it was. I remember now. Yeah, so that's why we want better embryos.
Right.
Yeah, so it did implant and then it was blighted ovum, so we had to sort of start over, which was very difficult.
So this embryo is after PRP that is got what we are so far, and can't wait to see the baby. So good in 2 months.
Amazing.
How it must be difficult, like the process, having a miscarriage, and then finally now you're pregnant. Yay! What is? Do you want to, like, how do you get the strength and resilience during this process? Because when we met, when we're looking at the years, I was like, oh my God, Kelli, when was this? Like 2.5, like it takes 2 years ago?
We took some breaks.
2020.
My husband and I definitely took some breaks before doing the first transfer, and just to like breathe between retrievals a couple of times. There were some breaks. But I first went in March of 2021, and then this transfer was in August of 2023. The successful transfer.
Right.
I mean, and they were both successful, and then they both implanted, but the first did not result in live birth. And
what did you do differently, though, Dr. Hade, after the first failed miscarriage? You guys didn't, you just, let's go again, basically.
Right, because it wasn't obviously an embryonic issue, because it was a blighted ovum. It has nothing to do with Kelli's uterus, which is the lucky part.
Fantastic.
Because all that means is I needed to find the right embryo.
Right. I felt like the miscarriage, I had been in this sort of journey is the word that's used a lot. I don't know if I really like that word very much for it, but I'd been going to the doctor. I'd been we had been medically pursuing pregnancy for a long time. And so the miscarriage was really hard, but also felt, it was part of the process, sort of. I was being monitored very closely by a doctor at that point. If I had conceived naturally and miscarried at 6 weeks or something, and we wouldn't have known then.
Right.
So I felt like I was supported already by a doctor in a clinic. That I feel like maybe that was a little. It wasn't easy. Obviously, it was really hard. But I felt like, okay, well, we got more embryos. Let's just. The hardest thing was just waiting to do another transfer, which we did have to wait a while for things to. The first ERA wasn't great. I think we had some infection.
Right.
So we had to do another one. But, yeah.
Fantastic, Kelli. As we're wrapping up, I just want to have some few questions because I know you're going to close. Thank you. I just cannot believe you're pregnant at 31, 2, whatever weeks, and came all the way here and having this lovely conversation. This is like a joy. We should I know you cannot party now, so we should just cheers at the end of this.
I really enjoy talking about it and sharing my story. I really do, and I'm so thankful to Generation Next, to both of you, and Dr. Nijat as well. I've worked with him a bit too, and so
we are like a team here. It's like
oh my gosh,
fours or threes,
a
fours now.
Clinic.
Yeah. Thank you so much. I want to, because I know you were with us for a time frame. How would you share with some audience who are like you, who went to acupuncturists or who's still trying naturally, and now they're first seeking for an office for Dr. Hade or Dr. Luke or whoever the doctor they're seeking, or an office that they want to go? What are the words that you would like, the words of wisdom that you want to share with the audience who went through the 2 years ago, who started knocking on doors and looking through the landscape?
Don't make a plan. That you can't really make a plan. You kind of just have to take things one step at a time, and it's a roller coaster. You think things are going well, and then they're not. Just hopefully but do you know what I'm saying? Like just take things one day at a time.
Yeah, gotcha.
Don't panic from it's very difficult not to panic from a bad diagnosis, but that's my advice.
You were holding strong, just FYI, the diminished ovarian reserve. It was really bad, like the image number, and
it was really bad.
But I think really the big take-home message here is persistence.
Yes. Yeah.
Most people are not persistent, and they feel too self-defeated, and they drop out of the game too early on. In my opinion, that happens to many people. And I've actually looked at data. I'm embarrassed to tell you how old I am, but I've been looking at this for decades.
Right.
And
definitely.
when you start to look at people who, if you're you'll have a 90% success rate of pregnancy and live birth within 1 year of infertility services if you're persistent and follow the directions of what the therapies are delivering and how do you evolve with the therapies to keep evolving. The whole key is that you don't go down the same road more than twice, right? You want to keep evolving in the therapy. But some people say, they have limitations on what they could do, either financially, emotionally.
Right.
There's a whole host, or ethically or religiously, what they're apt to do. And, that's why, I always applaud people like you, to be honest, who are persistent and you want something in life, right? And you're open to an evolution of, hey, we're not sure if certain things will help. There's some data out there and I may have limited experience, but if you're willing to trust me, the expertise, then let's try it together and see if we can improve the outcome.
I was very lucky to be able to financially follow through with it. I do remember Googling after my first meeting with Dr. Luke, Googling how to have success in IVF. Just I don't know where to start. And persistence was one of the things that I read, and I believe that that's true, and I believe I was just very fortunate to be able to be persistent.
Yeah, but there's a balance too, but it's true. Kelli is amazing. She also was evolving the persistently and doing different things. We're trying different things like PRP,
luteal phase stim,
right? Stim. But it is really hard. Also the balance between that, because we have patients over. I was like, take a little break before we go. And this is where I think why we have this podcast and so forth, is trying to give them all these different thinkings and skill set, because not everyone's persistent. Some women like to take different breaks. Some people may not have a partner that's supportive. Is like everyone and all the money or the financial resources to do certain things, can they do other things? So those are the things that I hope the podcast can help different patients. So, well, thank you so much, Kelli, for coming in, and thank you, Dr. Hade.
Thank you, Dr. Luke, as always.
It's a pleasure talking
nice
to both of you,
you.
and congratulations.
Thank you.
Yes,
This is amazing, and
Thanks.
hopefully we'll see the baby pictures.
Yeah, we're really excited. We will send them over.
8 weeks. Okay, we will.